Our patient, Mr. Prakash D'Souza, is a 44-year-old man who's had Parkinson's disease for 8 to 9 years now. Initially, what started off with tremors of the right side and a little bit of slowness has progressed to fully blown Parkinson's disease, which has made his life very difficult. He finds it difficult to perform his day-to-day activities and he has had to refrain from doing his regular work. In spite of medications, he probably has around 30% of his time during the day where he can do all his activities.
ನನ್ನ ಹೆಸರು ಫ್ಲೋರಿನ್, ನನ್ನ ಹಸ್ಬೆಂಡ್ ಹೆಸರು ಪ್ರಕಾಶ್ ಡಿಸೋಸಾ. ನಾವು ಮಂಗಳೂರಿನವರು. ಇವರಿಗೆ 40 ವರ್ಷ. ಒಂದು 7 ವರ್ಷದ ಹಿಂದೆಯಿಂದ ಇವರಿಗೆ ಸ್ವಲ್ಪ ಕೈ ನಡುಗುದಿತ್ತು. ಅದನ್ನು ನಾವು ಅಲ್ಲಿ ಮಂಗಳೂರಲ್ಲಿ ತೋರಿಸಿದ್ವಿ. ಅಲ್ಲಿ 7 ವರ್ಷದಿಂದ ಟ್ರೀಟ್ಮೆಂಟ್ ಮಾಡಿದ್ವಿ. ಆಮೇಲೆ ನಮಗೆ ಒಬ್ಬರು ಡಾಕ್ಟರ್ ಅಜಯ್ ಸರ್ಗೆ ರೆಫರ್ ಮಾಡಿದ್ರು. ಅದರಿಂದ ಬಂದ್ವಿ. ಅಜಯ್ ಸರ್ ಹತ್ರ ಮಾತಾಡಲಿಕ್ಕೆ ಬಂದ್ವಿ, ಅವರಿಗೆ ತೋರಿಸಲಿಕ್ಕೆ.
He came to us earlier this year and we suggested to him deep brain stimulation surgery for Parkinson's disease, which would be quite useful and he would have a very good improvement of life. He underwent detailed evaluation with a levodopa challenge test, a neuropsychology assessment, a psychiatric assessment, and after ticking all the boxes, he's here with us today in theatre to undergo deep brain stimulation surgery.
Hello, I am Dr. Shivkumar R, HOD and Senior Consultant Neurologist with special interest in movement disorder and deep brain stimulation. I am here to take you through the steps of Parkinson's journey, starting from medical treatment and then deep brain stimulation. So initially, most of the patients Parkinson's respond very well to medical treatment. Few years they are well with medical treatment, and once they start facing complications like motor fluctuations, poor response to medications and side effects of the medication, we plan for a treatment called as deep brain stimulation, where we implant the electrodes in the brain and stimulate the brain where the medications are not working. Most important step before we decide for deep brain stimulation is something called as levodopa challenge test. It's a simple question to answer whether the Parkinson's which the patient is suffering is responding to a drug called dopamine or not. How do we do this test? We stop all the medication what the patient is taking for 12 to 24 hours, and then we call them, and then we do something called as pre-levodopa assessment by doing a score called as UPDRS. Then we challenge them with supra-threshold dose of levodopa, and then we re-examine them at regular intervals for about 30 minutes to 1 hour and see whether they have adequate response, which is defined as more than 30 to 40%. Once this is confirmed, we say that patient has got dopamine responsive Parkinson's, which is a very good criteria for us to select for deep brain stimulation.
Let's now go and see what we have planned, how we have planned the trajectories into the subthalamic nucleus. This is a specialized computer which allows us to view the subthalamic nucleus with great detail, and we plan the trajectory according to known landmarks. And once we plan the trajectory, we make sure it is properly placed and is not going through any blood vessels, because if it goes through blood vessels, then the risk of bleed remains high. Once the planning is done, we proceed to the operation theatre, wherein we will put something called a Lexel frame. Lexel was a neurosurgeon who developed a 3D apparatus to target deep nuclei in the brain as early as the 1960s, and this device has been in use till date. And once we place what we call the Lexel frame, we will go down to the CT room, get a CT scan, and come back, merge that with his pre-existing MRI so that we can get something called the X, Y, and Z coordinates, which is similar to what we get on a GPS system of a car. With the X, Y, and Z coordinates of each side, that is the right side and the left side separately, we will target the subthalamic nucleus in our operation.
In this step, we are preparing the Lexel frame to mount on the head frame we fixed earlier, and to mark the exact location from where the electrodes will pass into the skull. After preparation of the scalp, a burr hole is made, which is around 14 millimeter. A burr hole cap is mounted, which will finally fix the electrode in its place. What you see in this frame is a microelectrode which is being inserted, which will record activity of the location where we are implanting our electrodes.
The next critical step in the OT is something called as intraoperative monitoring. So what we do in this test is two steps. One, we record from the deep nuclei of the brain by using something called as microelectrode recording, and then we stimulate the brain with the help of a macroelectrode and see for effect of this current, and also look for something called as side effects. So in the first step, we implant the electrode, we record the potentials using a special program, and we make sure that we are in the right target. In the macro stimulation, we stimulate the part of the brain surrounding the nuclei and see for side effects, and ensure that the electrode is in good position and a good outcome is expected. This is the plan of intraoperative monitoring.
This is the computer system which records single cell activity of the subthalamic nucleus where we are inserting the electrode. You can see the firing patterns of each nucleus are very specific, and that is what we use to make sure we are in the right location. You can see a clear difference in the pattern with stimulation off and on, with stimulation off being very slow, and when the stimulation is on, the slowness in the movements have improved. The location of the electrode is confirmed by fluoroscopy, and then the final electrode is placed in its target. We now proceed to do the exact same thing on the right side, and a burr hole is now being made. This is the final image of the electrodes confirmed by fluoroscopy, and you can see our patient is very comfortably getting off the cot.
So now that we have done the surgery successfully, we've also got a CT scan which has showed that there is no bleed along any of the operative tracks, and we've got that CT scan and loaded it onto our computer, and as you can see, the electrodes are perfectly placed. So this is the final moment when we can say that we have achieved what we started off for in the morning, that is placing both the electrodes in the subthalamic nucleus. Now we will go back and put what we call the pulse generator. That is a small operation done under sedation, wherein we tunnel all the wires through the skin and put the pulse generator, normally the right side of the chest. It is similar to what cardiac pacemakers are, and the cardiac pacemakers are normally placed on the right side of the chest wall, and we do the same thing with a brain pacemaker too.
The last part of the surgery is that we need to check the impedance. It's compulsory that all our contacts shown during the impedance are green and the impedance remains in range. If the impedance is in range, that confirms that our all connections are intact and we are done with the surgery.
Once the electrodes are implanted in the brain, then we usually wait for a few days for the brain to heal properly, and then we start something called as DBS programming, which is done usually 2 to 4 weeks after the procedure. In this programming, we try to stimulate the electrodes which are implanted and look for the effect as well as the side effects, and try to find out which is the best current and best position of the electrode which will give optimal result for the patient. Once the programming is done, then we start reducing the medications depending on the response gradually over a period of time. Usually good programming takes somewhere between 3 to 6 months for the patient to get adjusted and to have optimal outcome. So waiting for the programming to be effective is very important after the procedure is done.
After checking the impedance of all the electrodes, we turn on the device, and as you can see, Mr. Prakash D'Souza, who was not able to walk before his device was turned on, is walking very comfortably after that.
To summarize, deep brain stimulation is one of the most effective advanced therapies for treatment of advanced Parkinson's disease. This has helped many people to live their normal life for many years after the deep brain stimulation is done. So to conclude, precise selection of patients, surgical technique which should be appropriate, and good programming, most of the Parkinson's patients can lead a normal life after DBS, at least for the next 1 to 2 decades. Thank you.
ಈಗ ನನ್ನ ಹಸ್ಬೆಂಡ್ ತುಂಬ ಖುಷಿಯಾಗಿದ್ದಾರೆ. ಅವರಿಗೆ ತುಂಬ ಖುಷಿಯಾಗಿದೆ ಆಪರೇಷನ್ ಆದಮೇಲೆ. ತುಂಬ ಥ್ಯಾಂಕ್ಸ್ ಅಜಯ್ ಸರ್. ನೀವು ಪೇಷಂಟ್ ಹತ್ರ ನಡ್ಕೊಳ್ಳುವ ರೀತಿ ತುಂಬ ಖುಷಿ ಆಗ್ತದೆ ನಮಗೆ ನೀವು ತುಂಬ ಸಹಕಾರ ನೀಡಿದ್ದೀರಾ. ತುಂಬ ಥ್ಯಾಂಕ್ ಯು ಸೋ ಮಚ್. ನೀವು ಈ ಕಾಯಿಲೆಯಿಂದ ಬಳಲುತ್ತಿದ್ದರೆ ನೀವು ಯಾವುದೇ ಭಯ ಪಡೋದು ಬೇಡ. ಮಣಿಪಾಲ್ ಹಾಸ್ಪಿಟಲ್ ಸರ್ಜಾಪುರ ಮಣಿಪಾಲ್ ಹಾಸ್ಪಿಟ್ಲಿಗೆ ಬಂದು ಅಜಯ್ ಸರ್ಗೆ ಮೀಟ್ ಆದಮೇಲೆ ನೀವು ಸರ್ಜರಿಯನ್ನು ಮಾಡಿಸಿ ನಿಮ್ಮ ಲೈಫನ್ನು ಸೇವ್ ಮಾಡಿ. ಯಾಕಂತ ಹೇಳಿದರೆ ಅಜಯ್ ಸರ್ ಅಂತ ಒಳ್ಳೆ ಡಾಕ್ಟ್ರು ಯಾರು ಸಹ ಇಲ್ಲ.
There are a lot of Parkinson's patients out there who are afraid of deep brain stimulation surgery because they think it is an invasive procedure. This video is meant for each and every one of them to debunk the myths of deep brain stimulation surgery, establishing its safety and the outcome of DBS surgery. When deep brain stimulation surgery is performed at a center with all the equipment and expertise that is required to perform these surgeries, as you can see, the outcomes are fabulous and patients will benefit greatly. Anybody who is having a doubt about deep brain stimulation surgery, I think you should watch this video to know more.